All right. The first bill I'd like to deal with tonight is on page 4 of your calendar. It's House Bill 5295. It's sponsored by Chairman Solomon. The reason we're taking it out of order is there are several physicians that wish to testify, several of which apparently start a shift at 6 o'clock. So they asked to be accommodated. So it's an act related to animal and animal husbandry, animal care, its use of animals in medical training, and it prohibits a medical training program from using live animals if another accredited training program in the same medical discipline does not use animals or if an alternative teaching method exists. Chairman Solomon, the floor is yours.
Thank you, Mr. Chairman and members of the committee. I introduced House Bill 5295 to address what I and most of the medical community believe is an ethical and educational shortcoming, namely the use and killing of animals to train physicians. Everyone expects healthcare professionals to receive the best training possible. This bill would ensure that all medical training programs in our state use methods based on human anatomy and physiology whenever available, in place of the outdated use of animals. It is a common sense approach that ensures that Rhode Island will be a leader in medical education. This issue came to my attention when I learned in 2019 that live pigs are used as part of the Joint Emergency Medicine Residency Program. I was shocked to hear of this practice at such highly regarded institutions, and I was further surprised when I learned that 97% of similar programs across the country teach the same procedures without animals. The evidence in favor of replacing animals for medical training is clear and strong. First, in the field of medicine, live animal use is either a thing of the past or very rare. Secondly, advances in synthetic training devices known as simulators over the last 2 decades mean that there is effectively no medical procedure for which animals are necessary. Consider that using live animals, including dogs, to train medical students was commonplace just 25 years ago. But today, there isn't a single U.S. medical school doing so. Consider that every single pediatrics residency program in the country has ended animal use where cats and ferrets were once commonly employed to teach difficult airway procedures. It's my understanding that the Rhode Island Hospital Brown program uses animals primarily or entirely for the training of emergency airway procedures. Ironically, human-modeled simulators for such procedures are plentiful. And numerous studies show that those devices are equivalent to or better than using animals to train physicians and other healthcare providers. I could go on, but you're going to hear from several physicians today in support of this bill, so I'll let the experts provide more evidence. But let me repeat that 97% of emergency medicine programs in the U.S. do not use animals to train residents. Programs training without animals include the Joint Kent Hospital in Warwick, Beth Israel Deaconess Medical Center, Boston University, Massachusetts General Hospital, the University of Connecticut, and Yale. This is the right thing to do, but it's also the popular thing. Lastly, in 2019, the editors of the Boston Globe, not a columnist, but the entire editorial board declared that it's time for a humane change at Brown and urged the university to stop using animals to train doctors. On this issue, Brown and Rhode Island Hospital are extreme outliers in New England, and because of that, they're attracting a lot of negative attention. And I would ask that you vote in favor of this legislation. I'll take any questions.
Any questions for the sponsor? Thank you, Chairman Solomon. The first witness is John Pippin from the Physicians Committee for Responsible Medicine. John Pippin? John Pippin? Dr. Pippin?
Yes.
You're on the air.
Thank you. Yes, thank you, Mr. Chairman and members of the committee.
You're on the air.
Thank you. Yes, thank you, Mr. Chairman and members of the committee for the opportunity to speak today. My name is Dr. John Pippin. I'm a cardiologist. I received my medical degree from the University of Massachusetts.
Dr. Pippin,
Yes.
can you hang on a second? Can you turn down whatever device you have in the background that's broadcasting your voice? Dr. Pippin, can you hang on a second? Can you turn down whatever device you have in the background? I know.
Yes, I have no device on in the background.
Oh. I don't know where it's coming from. Okay, we'll try.
On in the background. Shall I continue?
Yes, sir.
Okay, thank you. I won't go through my introduction again. I'm a cardiologist, Dr. John Pippin. I received my medical degree from the University of Massachusetts. And I completed my fellowship at Beth Israel Deaconess Medical Center in Boston. I have served on the faculties of Harvard Medical School, the Medical College of Virginia, and the University of Texas Southwestern Medical School. I was the founding director of cardiovascular medicine and medical imaging at the Cooper Clinic in Dallas. I'm here today on behalf of the Physicians Committee for Responsible Medicine, a national nonprofit with more than 175,000 members that advocates for preventive medicine, conducts clinical research, and encourages the highest standards of ethics and effectiveness in research, testing, and education. We strongly endorse Representative Solomon's bill. H 5295 would address a glaring problem in Rhode Island. 97% of emergency medicine residents in the United States and Canada, that's 278 programs, do not use animals to train their physicians. Yet the Rhode Island Hospital and Brown program inexplicably continues to use and kill pigs, a practice at extreme odds with prevailing trends in physician education. For the last 16 years, I have overseen my organization's work to modernize medical training by promoting educational methods modeled on the human body as upgrades to the antiquated use of animals. I have engaged with faculty at hundreds of medical centers, and I have seen time and again those medical centers join the overwhelming ranks of their peers. In just the last few years, emergency medicine programs across New England have changed. At Bay State Medical Center, Maine Medical Center, Dartmouth College, and Beth Israel Deaconess. In fact, in the entire region, only the Brown Rhode Island Hospital program is clinging to the past by using animals. By way of very recent addition, just yesterday, the elite emergency medicine program at Vanderbilt University informed me that they have halted the use of animals to train their emergency medicine physicians and use an entirely non-animal curriculum. And today we were notified by the new Kaiser Permanente Modesto Emergency Medicine Program in California that from the very inception they will not use animals to train their residents. As physicians, we take an oath to first do no harm. I believe that oath requires that we make the compassionate choice whenever there is one to make. In this case, harming and killing animals to practice procedures for which superior methods exist is clearly the wrong choice. Thank you for your consideration of my testimony in this important legislation.
Any questions of Dr. Pippin by the members of the committee? Seeing no questions, the next witness on our calendar is Robert Demuth.
Hello.
Hello, Dr.
Chairman and members of the committee. Thank you for your time. My name is Dr. Robert Demuth. I'm an internal medicine physician working in Des Moines, Iowa, with 20 years of experience treating wounded soldiers and civilians. I felt compelled to testify in support of Bill 5295 because my experience has shown me that not only is there no need to use animals to expertly train doctors, but using animals can actually impede training. I served as a flight surgeon with the U.S. Army's 2nd Armored Cavalry Regiment from 2001 to 2003. In August 2003, a massive bomb exploded outside the Jordanian embassy in Baghdad, launching a car onto the roof of a nearby building and killing 17 civilians. But more people could have died if not for the quick work of the Army medics whom I trained. That day they saved lives without ever practicing procedures on animals. Instead, I had trained them on high-tech simulators that mimic human anatomy. In the days after the embassy bombing, I got emails from medics who had responded to the carnage. One after another told me how valuable their simulator training had been. Later, when I was deployed to Iraq in 2005 and 2006, I treated many soldiers returning from what was called the deadliest road in the world. Soldiers who had been shot and who had suffered traumatic amputations from improvised explosive devices. I'm confident that practicing on simulators, not animals, helped me treat those brave men and women. Science backs that up. Studies by the American, Canadian, and Israeli militaries show that training on simulators is as effective or better than training on animals. U.S. Air Force medical training expert Major Andrew Hall even wrote in 2014, quote, "We have entered into an age where artificial simulator models are at least equivalent to, if not superior to, animal models," end quote. If we can expertly train Army medics to treat traumatic injuries without using animals, surely we can train the doctors at Brown and Rhode Island Hospital. I urge the committee to move this bill forward. Thank you for your time and attention.
Any questions of Dr. Demuth? Seeing none, we'll go on to the next witness, Robert Verganti. Robert, you're on the air.
Okay.
You can proceed with your testimony.
Any questions of Dr. Demuth? Seeing none, we'll go on to the next witness, Robert Verganti.
Yes.
Doctor, are you prepared to testify?
Robert, you're on the air.
Yes, I am.
Okay, go ahead.
Mr. Chairman and members of the committee, thank you very much for the opportunity to speak in support of House Bill 5295, which would raise medical training in Rhode Island to a national standard. My name is Dr. Robert Vergnani. I'm a resident of Portsmouth and have been for over 45 years. I'm a retired ophthalmologist who practiced medicine here for 41 years. When I was in medical school at Georgetown University in the 1960s, our curriculum, like most medical school curricula at the time, included a dog lab. Myself and other students entered a room where an unconscious dog was tied down on a table and incubated. We were then required to perform surgical procedures on the animal before it was killed. To this day, I can't tell you what the point of that exercise was. It seemed cruel and useless then, and it seems cruel and useless now. I am heartened to see that things are considerably different in 2021. As you heard before, not a single American medical student uses live animals today, and at higher levels of training, including residency programs, animal labs are quickly being replaced. This is even true in emergency medicine, the area of training where Brown University and Rhode Island Hospital continue to use animals. As you heard, 97% of emergency medicine residency training programs in the U.S. and Canada do not use live animals. Instead, they use simulators, cadavers, and other non-animal methods. Why does Brown/Rhode Island Hospital program remain a conspicuous outlier? Thank you for your time.
Thank you, Doctor. Any questions of the doctor? Yes, Doc Corvesi.
Dr. Vignani.
Hello, Dr. Corvesi.
Do you remember me?
Vividly. I remember the years we worked together.
I cannot tell you there are very few times I have ever been more pleasantly surprised attending any committee meeting ever. I can't tell you how much I enjoyed your testimony and hearing your voice. I cannot tell you how respected this man is. And whatever testimony this man gives, you take it to the bank. I worked for Dr. Vignani and Dr. O'Brien for 13 years in Fall River. Two of the most ethical, compassionate, capable, and competent physicians I have ever had the pleasure of meeting in my 40 years of being an optometrist. Dr. Vignani, it was a pleasure to hear your voice today. What a surprise. I cannot wait to tell my wife tonight.
Well, thank you, Dr. Cavesi. Thank you very much.
It was a pleasure to hear from you.
Thank you again.
Any other questions or reunions from the of the members of the committee?
All stated, Chair.
Seeing none, the next witness is Carrie Foley. Dr. Foley?
Yes,
Seeing none, the next witness is You're on the air. You can testify.
thank you.
You're welcome.
What a surprise that.
Mr. Chairman and members of the committee, can you hear me okay?
Yes.
Yes, can you hear me?
Yep.
The next witness is, you're on the air. You can testify.
Thank you.
You're welcome.
Thank you for the opportunity to speak to you today.
Yes.
Can you hear me?
Yep.
My name is Dr. Carrie Foley, and I'm a retired physician. I was residency trained and board certified in emergency medicine and practiced in level 1 trauma centers in the Washington, D.C. area for more than 25 years. My experience tells me that Representative Solomon's bill is essential to improving medical care. Doctors from Brown and Rhode Island Hospital will tell you that they must use live animals to train emergency physicians. That is not true. They will tell you stories in which their graduates saved people's lives, and they'll insist that that couldn't have happened without first practicing on pigs. That is also not true. Every year, hundreds of emergency physicians finish their training and begin saving lives in hospitals across this country, including those here in Rhode Island. Almost none of them, and let me emphasize that, almost none of them will have ever practiced on a live animal. This isn't a hypothetical. Everywhere you look, people are being saved by doctors who trained on models that replicate human anatomy, not on pigs. One day, years ago, I was on call in the ER when a construction worker was brought in. He'd been in an accident, and a beam had crushed his neck. His airway was blocked, and we could not intubate him orally. He had ruptured blood vessels in his neck that were causing a big hematoma to grow and grow, which was pushing against his trachea. Time really was of the essence. I cut into his neck to access his airway, and I successfully inserted a tracheotomy tube, a tube into his neck. He began breathing again, and I was able to get him into surgery. That procedure is called a cricothyroidotomy, and at Brown and Rhode Island Hospital, they use pigs to teach it. But not once have I ever looked back at the time I helped that man or any other people that I had to perform that procedure on and thought that I would have been more prepared if I had practiced cutting open a pig's neck. Throughout my training to become an emergency medicine physician, never once was I required to train on live animals. I served as an assistant professor of emergency medicine at Georgetown University School of Medicine and oversaw the education of emergency medicine residents who were trained with exclusively human-based methods. The devices available today for training emergency procedures are impressive. They simulate human anatomy and physiology. They have flowing blood, breakable bones, and layers of skin, muscle, and fat. There is nothing a physician can learn from practicing on animals that he or she cannot learn from simulators. Thank you for your consideration of my testimony on this important matter.
Thank you, Dr. Foley, for your testimony. Are there any questions of Dr. Foley from the members? Seeing none, Margaret Peppercorn is the next witness. Dr. Peppercorn,
Yes.
you may proceed with your testimony.
Hello?
Yes, you're before the
Chairman
House
Craven.
Judiciary Committee. You can proceed with your testimony.
Thank you. Thank you, Chairman Craven and the committee. My name is Dr. Margaret Peppercorn, and I'm speaking in support of House Bill 5295. I'm a physician who graduated from Harvard Medical School, and I was in private practice for over 30 years in Massachusetts, but now have a home in Portsmouth, Rhode Island. Some of what I have to say, other physicians have already commented on. When I was in medical school, like the other physician who spoke, we had to do dissections, surgeries, and physiology experiments on living dogs who were later euthanized. I actually still have nightmares from those experiences and deep regrets over ever having done them. This was in the late 60s when there were few alternatives. But since then, there are many alternative methods that have been created and perfected and are now being used across the world to train medical students and physicians every bit as well, if not better, and without harming any living creature. In fact, as you've heard, all the emergency medicine programs across New England have now stopped using live animals to train residents, except the program at Brown and Rhode Island Hospital. We all obviously want the best training for physicians, and as a physician myself who over the years had to sometimes suddenly confront emergency situations with patients, I totally understand the need for physicians to learn competence doing all the possible emergency procedures before first facing a live living person in distress. I just don't see animals as good models for humans. Training on the simulators we now have that actually look, feel, breathe, and bleed like a person provide a much more accurate preparation for treating human patients than poking tubes into pigs. Using living animals is not only an inferior teaching method in my mind, but it's also cruel. It clearly harms the animals, but it also harms the students, since it instills a callousness and disregard for suffering by forcing them to ignore the harm that they're doing to the animal they're working on. And I actually see no justification at all for using and harming living animals the ways we did decades ago, especially since better methods now exist. And I think Rhode Island should bring its medical training into the 21st century like other places have done, and should insist on the statewide use of human-focused, human-based, humane training methods. And therefore, I very strongly urge you to support H5295. Thank you.
Thank you very much, Doctor. Any questions of Dr. Peppercorn? Seeing none, we'll go on to the next witness, Dr. Frank Foltes.
Chairman, he was disconnected and we're just recalling him.
Okay.
Chairman, it's Samuel Finn.
Dr. Finn,
Yes.
you're on the air and you're speaking before the House Judiciary Committee on the bill that you signed up for. So you can proceed
Right.
when you're comfortable.
Thank you. Mr. Chairman and committee members, thank you for your time today. I will try not to be too repetitious following my multiple colleagues. I'm here in support of Bill 5295. Are you hearing me okay?
Yes, I am.
Okay. I worked for 30 years as an emergency physician, including 25 years in the busiest emergency department in Washington State, where we frequently treated up to 200 patients a day. I served as chair of the Emergency Department Operations Committee for several years, chair of the Hospital Medical Staff Quality Review Committee, and medical advisor to multiple fire departments within the county, supervising EMTs and paramedics.
Over the years of my training, I took part in several teaching labs in which animals were used to teach the procedures we're discussing here, including surgical airway, emergency thoracotomy, which is the last-ditch procedure in which the patient's chest is cut open to stop severe internal bleeding, emergency chest tube placement, central venous catheter insertion, and others. It's critical that emergency physicians have expertise in these procedures. They are fortunately not needed frequently, but can be life-saving when needed. For years, it has been established that they can be taught using various simulator mannequins to model human anatomy. You've heard multiple other physicians talk about this. It is no longer necessary to sacrifice pigs, dogs, or other animals to learn these procedures. And as you've heard, the vast majority of training programs around the country, both for emergency physicians and for surgeons, have stopped these practices. My experience with such animal labs showed me that the emotional stress created in such settings is not based on the urgency of the situation, as in the resuscitation of real patients, but rather in the knowledge that one is gravely harming innocent animals, despite that they are anesthetized, and that they will be put to death after the exercise. I clearly recall fellow trainees emotionally traumatized and leaving such labs in tears or simply refusing to participate. I believe you have access to several research studies from Harvard, U.S. Army, and elsewhere that bear out the equivalency of such training done on simulators. There's truly no advantage to sacrificing live animals for these procedures, to teach these procedures. Thank you for your time and attention.
Thank you, Doctor. Are there any questions of Dr. Finn? Yes, John.
Thank you, Mr. Chairman. Doctor, this is John Lombardi. How are you this evening?
I'm fine, thank you.
Good. I just have a quick question. You may not know the answer, and that's okay. I'm just in my own mind. You're saying Brown University and Rhode Island Hospital. What are the other Ivy League schools? Do they participate in live animals, or do they do the alternatives as you stated?
Well, I can't really answer that myself. I'm a physician in Seattle, and I'm not familiar with those programs, but from what I've heard from the other doctors and from what I've learned from PCRM, no, there are no other programs that use animals for training.
Okay, thank you, Doctor. I appreciate that. Thank you, Mr. Chairman.
Okay.
Any other members of the committee have questions of Dr. Finn? Seeing none, thank you, Doctor, for your testimony. And the last witness is Dr. Frank Foltis, who I think we have on the line now. Dr. Foltis?
Yes.
You're on the air.
Thank you.
Animals for training.
Okay, thank you, Doctor. I appreciate that. Thank you.
Any other members of the committee have questions of Dr. Finn?
Yep.
None, thank you,
You
Doctor,
can proceed.
for testimony.
You can just talk
Okay.
over that.
This is Dr. Frank Foltis, who I think we have on the line now.
Right, yes, hello. Mr. Chairman and members of the committee, thanks very much for the opportunity to speak to you in support.
Dr. Foltis?
Yes.
Yes. You're on the air.
Okay.
All right, can you hear me now?
Yes, we can.
Mr. Chairman and members of the committee, thank you for the opportunity to speak to you in support of House Bill 5295. My colleagues have made some very good points. I will try to cut mine even shorter. I'm Frank Foltis, a resident in Providence. Mr. Chairman and members of the committee, thanks very
You can
much.
proceed. Just talk over.
I have practiced medicine in Rhode Island for over 42 years. I've done both a psychiatric and medical residencies and worked in an emergency room for over a year. I am not unfamiliar with surgical procedures. And I am currently clinical assistant professor of psychiatry emeritus at Brown. In the 1970s, when I was in medical school at Tufts University, we performed surgical procedures on a dog before it was destined to be killed. I can still visualize with horror having to cut open that dog and questioning the value in my education. These sort of pointless and cruel exercises were widely accepted in medicine back then, but no more. Today, cutting up and killing animals is the extreme exception. Even back in 2016, the University of South Carolina abandoned using animals because they knew that simulators were going to be better for their emergency room resident program. You know, Brown and Rhode Island Hospital have insisted that using live animals was superior in training. And if you think about it, this logically says that universities such as Harvard, Stanford, and Johns Hopkins are settling for second-rate training. Well, obviously this is not true. Using live animals is antiquated. I appreciate your letting me make my comments. Bye now.
Thank you, Dr. Foltis. Any questions of the doctor? Seeing none, that concludes testimony on House Bill 5295, sponsored by Chairman Solomon. We, unfortunately, will have to go back to 5295. We discovered there were 3 witnesses that didn't get a chance to testify. I don't know if they're available yet. Okay. So we'll reopen the testimony on House Bill. That's Representative Solomon's bill. And I believe the first witness that signed up for is Dr. Klein. Dr.
Yes.
Klein, are you on?
Can you hear me?
Yeah, I can. Yes. Proceed. You're testifying right now before the House Judiciary Committee.
Thank you, Chairman Craven, for allowing several of us who are opposed to 5295 to speak. We submitted written testimony, and several of us are available to provide verbal testimony. I want to thank the committee for having us. I wanted to start by just telling you that I'm a Rhode Island native. I'm a graduate of Brown Medical School, and I practice emergency medicine here in Rhode Island. I've devoted my professional life to providing emergency care to the people of Rhode Island and to educating the next generation of emergency physicians to do the same. I'm the Vice Chair for Education in our Department of Emergency Medicine at Brown, and in that role I oversee all of our training programs, and I'm ultimately responsible for the quality and integrity of the education that we provide. And over the years, many of us are proud to say that we've built up one of the most competitive and highly sought-after emergency medicine training programs in the country. I just have a few key points. I've provided written testimony that you can obviously review, but I want to start by just conveying the depth of consideration that goes into this program. Every year we conduct an annual review, working closely with our veterinarians, simulation experts, educators, and an extensive review of the medical literature. And that process, combined with the published peer-reviewed studies and common sense, all support the conclusion that mannequins, plastic models, cadavers, and other static modes of training are not appropriate substitutes for the live tissue model. They are necessary but insufficient for the training that demands prompt decision-making and technical skill in an urgent, life-threatening situation. I can provide the committee with an extensive list of references that establish that fact. And you've heard tonight a statistic being thrown around by members of the Physicians Committee for Responsible Medicine, about 96% or 97%. Even Representative Solomon quoted that. I would just ask, where that data comes from. This, in my opinion, is self-referential assertion that is posted on the PCRM website. To my knowledge, it's never been undergone any peer review. The methods and data are not available, and so it's not something that in the medical community we would accept as a scientific fact. I also want to point out that several of the people you'll be hearing from tonight are members of the emergency medicine community here in Rhode Island. And I put a fine point on that because many of those that are supporting this bill are from out of state or from other specialties or have not been actively practicing in Level 1 Trauma Center for most of their careers. The question I raise about this issue is, really, what is this about? On its face, this bill might appear to be about animal rights and animal safety, but I think you have to step back and look at and ask yourself, when you look a step further, the big picture here is this is about people, and specifically it's about the people of Rhode Island. It's about their safety. It's about the confidence and the trust they place in us when they have a life-threatening emergency. And they come to the emergency department with the expectation that we will provide them with the highest quality care, including providers that are battle-tested in real conditions to perform high-stakes, really performed procedures. And if I may invoke a brief clinical scenario, I happened to be on duty 18 years ago this month during the Station nightclub fire, where we had dozens of badly burned patients that required surgical cricothyroidotomies. They had inhalation injuries that resulted in rapid swelling of their airway, and without prompt, precise action, these patients would not have made it. And they are alive today for the skills that they learned in the live animal lab with battle-tested physicians. And to me, I will stand behind any negative attention that may come from animal activist groups about our animal procedure lab, if it means that we will save one human life based upon the technical skills our providers are learning. Thank you again for your time, sir.
Thank you, Doctor. The next witness that is prepared to testify. Oh, any questions of Dr. Klein? Seeing none. Dr. Alexander Dayton. Dr. Dayton?
Yes.
Can you hear me? You're testifying live before the Rhode Island House Judiciary Committee. Please proceed.
Thank you, sir. My name is Alex Dayton. I'm one of the emergency medicine residents at the Rhode Island Hospital Alfred Medical School EM residency program. I'm currently in my third year of training. I'd like to start off by thanking you for the opportunity to testify before the committee and to take part in the discussion regarding Bill 5295. I'd like to echo that our residency is dedicated to creating emergency physicians of the highest caliber so we can provide the best medical care possible to the people of this state. An essential component of our training is learning to perform high-acuity, low-occurrence procedures. These procedures require an immense amount of skill and are performed emergently during resuscitations with the goal of saving lives. We're meeting today to discuss the use of live animal models to teach residents how to perform a cricothyroidotomy. As we discussed before, the cricothyroidotomy is an emergent bedside surgical procedure used on patients who are unable to breathe for themselves when any other method of supporting them has failed. This procedure is so critically important that it's continuously taught throughout emergency medicine residency. In our program, our training in this procedure actually begins within the first 2 weeks on cadaveric models, and then the remainder of our program, we continuously readdress our training using various forms of mannequin models. And these forms of simulation certainly do help familiarity with anatomic landmarks and with the micro skills required to successfully complete the procedure. But as Dr. Klein had just said, they are unfortunately not sufficient. Live animal models allow for an unparalleled learning experience as the procedure is performed on a dynamic patient. These models teach residents to address complications such as bleeding, anatomic abnormalities, and hemodynamic instability in real time as they arise. And most importantly, live animal simulation forces residents such as myself to perform the cricothyroidotomy while simultaneously managing emotional stress of knowing that if we fail, we're going to lead to loss of life. And as a physician, there's no greater fear than loss of life that could be prevented. Approximately 6 weeks ago, actually, I had to perform an emergent cricothyrotomy while working in the emergency department. I, with 100% certainty, feel that the direct result of my live animal model training provided me with the skills and the confidence necessary to expeditiously perform this life-saving procedure. I truly believe that training on a live animal model allowed me to save a life and allowed my patient, who's one of your constituents, to return to their family. I know that many of us work in different professions, but we're all here for one common goal, which is to improve the lives of the people of Rhode Island. Our current training model at Brown allows us to provide optimal medical care to the people of this state, and I hope that we're allowed to continue to train in this manner. I'd like to thank you again for allowing me to share my experience.
Thank you, Doctor. Any questions of Dr. Dayton? Seeing none, Dr. David Lindquist is the last witness.
Dr. Dayton? Seeing none?
Hello.
Dr. Lindquist?
Hello.
Dr. Lindquist, can you hear me?
I can hear you. Can you hear me?
I certainly can. You're live on the air, and you're testifying before the House Judiciary Committee. Please proceed.
Thank you, Chairman Craven and members of the committee for this opportunity to testify against H5295. I've been the director of the difficult airway course for ground emergency medicine residents for 5 years, and I've been an instructor for over 11 years. I can state without reservation that practicing surgical airways, the cricothyrotomies we're discussing, on mannequins is inferior to the learning that occurs when practicing on a live anesthetized model. Rhode Island Hospital actually has one of the first simulation centers in the country. We've had it for over 20 years. We use mannequins as part of our training for the airway course. We also go over and above that using the live animal model because we've come to appreciate that using the plastic models cannot reproduce the anatomic variations, the handling of live tissue with surgical tools, and the challenge of troubleshooting a procedure when complications arise. These are not reproducible with the plastic models. We have an obligation to our residents when we are educating to provide critical emergency care to train them to the highest level of skill that we can achieve. I've received numerous grateful emails from graduates who have saved people's lives through successful cricothyrotomies. These new attendings, now shouldering the ultimate responsibility for patient outcomes, have written back to express their appreciation at the training they had received, specifically on the live anesthetized animal model. They described the confidence they had in their technical skill in performing this emergent critical procedure alone. Other residents have stated that within days of their training, they encountered the need for performing a cricothyrotomy during their next emergency department shift. These are active residents and active practicing emergency physicians who have done both the mannequins and the live anesthetized model and feel very strongly that there just is no comparison. I would further point out that H5295 would save no animals. I repeat, it would save no animals. The farm-raised pigs that are involved in these protocols are otherwise sent to the slaughterhouse to enter the food supply. So passing H5295 merely negates a crucial learning opportunity, leaving our residents less well-trained, but it saves no animals. This bill also would increase the risk for the citizens of Rhode Island. Nightly in our smaller hospitals in Rhode Island, emergency physicians are often the only physician on duty in the entire hospital able to intubate critical patients. To place our graduates in such positions of responsibility alone, where failure is not an option, without providing them the best training possible, is professionally irresponsible and potentially endangers our patients. Finally, as you are well aware, the COVID-19 virus can cause severe respiratory distress, sometimes requiring patients to be intubated. We need our emergency physicians to be able to bring their best skills to help the citizens of Rhode Island during this pandemic. Disrupting training is the opposite of providing Rhode Islanders with the best possible care. Therefore, as a graduate of Brown University's emergency medicine program, as a 17-year member of the faculty of Brown, and as a 21-year resident of Rhode Island, I strongly urge you to oppose H5295. Please permit us to maintain the highest level of training for our emergency medicine residents in order to provide the best critical care for the citizens of Rhode Island. I thank the committee and the chair for your time.
Thank you very much, Doctor. Are there any questions of the doctor from the members of the committee? Seeing none, then that concludes yet again the testimony on House Bill 5295.